and an opportunity for us to be reminded every day of the great privilege it is to be a surgeon and the many ways that we can help people with a skill that we have in our hands. And I don't know about the rest of you, but I had goosebumps during that presentation, and it's an important thing for all of us to remember that what we do affects real people and real lives. So with that, I will thank our presentations at M&M this morning for sort of being a lead-in to my conversations today, because we have some amazingly tremendous things to be very proud of here at UC Davis right now. And the evolution of this medical center over the time that predates me and recently has really been extraordinary. For people who've been here over the 40-year history of this medical school, which is really relatively young on the scale of medical schools, this has really been an extraordinary accomplishment. And it really parallels the growth in Sacramento and the Sacramento area as well in terms of sophistication, size of the population, all those things. And it really has developed in parallel that we really now have a world-class academic medical center to train doctors of the area and the region and to contribute to discovery in medicine. So today we're celebrating lots of things. This was announced last week. But for the first time, UC Davis was ranked in the U.S. News and World Report and came out of the gates as a winner. Number 6 in the state and the only ranked U.S. News and World Report hospital in Sacramento. It's a lot to be proud of. What you heard this morning was a representation of the fact that all of our outcomes are recorded, and I'm going to talk a little bit today about all the ways that there's much more transparency around what we do. Now, many surgeons say that's for better or worse, but from the point of view of a patient, it's all for better. To make decisions about what you want to do and to drive us to the highest standards. We learned a lot today, and surgery has led the way with taking careful look at the kind of work that we do. The history of M&M really started in the world of surgery in the 1920s and before, and is now promulgated to the rest of surgical care and the rest of hospital care. But the kind of work we did, looking critically at our outcomes, at our cases. Did we do the thoracotomy on the right side or not? No, we didn't. Let's all learn from that so that not each individual person has to make that mistake, but that we can inform each other. So I'm going to go over a little bit how the U.S. News and World Report methodology is done, mostly as a demonstration project for how many of these systems are utilized. So NISQIP we've all talked about. You heard a little bit about there's a trauma QIP, a cancer QIP, a bariatric QIP, all of the mechanisms that we review a lot of what we do. So first we'll talk about U.S. News and World Report. It uses a combination of publicly available data as well as proprietary algorithms that they set up. And their goal, in theory, is to identify the best medical centers across the country. Now, none of this is perfect, and there's lots of criticism about these things, and we all talk about the difference between administrative databases and regular databases, but nonetheless, this is the kind of information that is utilized. So for the 2014-15 rankings, approximately 5,000 hospitals were evaluated, and 144 of the 5,000 were ranked using their methodology in the top 50 in at least one of the specialties. And these were done across 16 adult specialties, so not every activity is looked at, and that's a criticism. For UC Davis this year, we ranked nationally, so in the top 50 of the 5,000 hospitals in 10 specialties, and we're high performing in 2 other specialties in adult services and 4 in children's services. So just again to look at the methodology on the adult side of the shop, some things that are looked at and are weighted is the reputational score, the survival score, which is directly related to published data, outcome data, patient safety scores, and some structural elements. So reputational only, so there are certain ones where it's just a survey and it's what other physicians say about you, and that's in ophthalmology, rehab, psych, and rheumatology. For the reputation plus these objective factors, you can see the 16 specialties that are listed below. So for UC-DMC, the reputation component is 27.5%. That's for everyone. And so the question is, how do they get that? You know, how do you know what somebody's reputation is? It's quite interesting to see what their methodology is. For all of you who've gotten requests to be members of Doximity, they actually, I don't know, how many of you are on Doximity? And how have you, recently there's been a survey about what are the best residencies that came out. So it's quite interesting that this is a methodology that's used. And I think part of it's because it used to be AMA membership, and AMA membership is actually quite small now, much smaller than the membership in the American College of Surgeons, of note. Survival scores, which is weighted a third on this, looks at hospitals' performance with regard to patient mortality. And they look at the 30-day observed to expected mortality rate for years 2010, 2011, and 2012. So it's 3 years prior to when they actually publish the data. So some of the information is real time, and some of it is based on the data in advance. And most of it comes from the Medicare database. So of note, in the 16 areas that we were involved, where we were ranked based on the previous data and then the current data that they looked at, for cardiology and heart surgery, nephrology, and pulmonary, we were listed as much better than expected. So this is similar to the NSQIP kinds of activities, but not a NSQIP rating. We had improvement in geriatrics, a little bit of a decrease in gynecology, but nonetheless still ranking in that better than expected score. You can see orthopedics, ENT, GI surgery. We were in the better than expected, though didn't quite reach the much better. So you say, where is surgery here? Because there's not a category that's just surgery, but you can find us in heart surgery, in a way, in what goes into nephrology, pulmonology, certainly cancer, and gastroenterology and GI surgery. Patient safety scores. You all hear about this. The residents talk about this. This is reported and gone over monthly through our QI process here. The indicators that are reported nationally, both through the Medicare databases, but also through UHC and a variety of other mechanisms. Again, there's lots of things to be critical about U.S. News and World Report. Nonetheless, it's a little bit comparative to what Dr. Freischlag talked about 2 weeks ago, the difference between comparative effectiveness and what you might call real-world data and efficacy data, which is a more rigorous analysis. But so pressure ulcers and post-op hip fractures were 2 areas that we were evaluated in, and again, this data was based on 3 years historical data. The structural elements, which are 30% of it, really reflect a lot of the growth and development of the medical center over this period of time in terms of developing some of the advanced technology issues related to the electronic medical record, having the availability of in-house intensivists, the National Cancer Institute rating, really I think is one of the things that helped move us into this category. So what was different this year than in previous years that helped us reach these ratings? One of them is component weighting, that there was more emphasis on the patient safety scores were increased from 5 to 10%, and the process was reduced from 32 to 27%. Technology, interestingly, the cardiac ICU was taken out of the cardiology and heart surgery component. I'm not sure what that means for us, but it's just one of the changes that occurred as the institution is sort of evaluating what these were. Urinary tract infections, someone was able to argue that this was not an adequate reflection of quality of care. And I know we've had some publications that have talked about whether certain indicators that have been identified by other organizations are meaningful in terms of really reflecting quality of care. So it's interesting that some of those factors do get picked up by other people who evaluate us. Everybody evaluates us. So this is really what people want to know. You know, where do we rank relative to our competitors in the region? And so here are the data for the top 10 in the state. And you can see from this that we are not very far off. If we were able to move 2 of our high-performing specialties into the area of nationally ranked, we would be tied with UCSF and UC San Diego. So there is, we are in the leagues with the big boys. Let's look a little bit at the performance overview. So compared to last year, we moved into the top 50 in the country in 10 of the specialties. So cancer, and again, I think a lot of that reflects our National Cancer Institute designation and all of the things that are necessary to have in place to make that occur. And I'll be a little more granular with our department coming up. Cardiology and heart surgery, again, really some outstanding outcomes work has been done in that area. The ENT, geriatrics, gynecology, nephrology, through which our surgical component is a part of, and interestingly, neurosurgery, orthopedics, pulmonology, and urology. No comment. It's a God somewhere. So again, just to look a little bit at the adult nationally ranked, where we were in each of those in that top 50 category. It's really some, I mean, if you look at across the country, this is pretty extraordinary to be in the top 15 in the country in pulmonology, nephrology, some of our other areas. I think people know for the first time in a decade, Hopkins, and of course, certainly our dean has paid attention to this. We attribute it all to her moving from Hopkins, but Hopkins was knocked off the #1 spot as the best hospital in the country to number 3. Just pointing out some facts. And on the children's side, really a lot of work has been done, and I think that this is reflective. We ranked 4 in 4 categories in neonatology, nephrology, orthopedics, and urology, and this is also in combination with our partnership with the Shriners Children's Hospital. So this is a little bit a harder slide to see, but it just shows you the number of hospitals that were analyzed in each of the areas, and again, our specific ranking, and therefore the percentile for us. So I think things to look at here are cardiology and heart surgery, cancer surgery. These are really extraordinary measures of outcome for us. Are they perfect? Absolutely not. Is it what everybody reads on the street? Absolutely. So what do we know? What do we think contributed to this? Certainly the nurse magnet accreditation that we received last year, or the first part of this year, contributed to pushing us over the top in that category. And many of the quality initiatives that many people in this room have been involved with, and particularly our residents, which I think really deserve to be highlighted here. The work that we've done has contributed a lot to moving these data, and again, reflecting the data done in 2010, 2011, and 2012. So, and the fact that it's less based on calling your buddy on the phone saying, oh yeah, we think this is a great hospital, and more on relatively objective criteria. So just things to remember, this didn't happen overnight. This really is a reflection of the continuous process improvement activities and the fact that people are paying attention. And this reflects and is correlated quite nicely with our NISQIP data, which I'll talk about a little bit as well. But people are paying attention and trying to do the right thing and making a difference. The work we've done on pressure ulcers, I think, is a great example. And it's not going to stop. This kind of emphasis on publicly reported outcomes, looking at complications, not accepting them, making sure that we learn from our mistakes are the kinds of things that are going to be important to quality. And it matters, again, as Dr. Pevic mentioned this morning, it doesn't matter if the incidence is low if you're the patient who has the problem, and being taken care of as though this is your family member, your parent, your child is the approach that we want to take. So what about the Department of Surgery? So what have we been doing and where are we? It's really the beginning of the year from our perspective. I know for a lot of people, and all your kids are out of school and it's summertime, but in the academic surgical world, we all start in July. So I just thought I would use the time a little bit to talk about, what are some of the important strategic initiatives for us? What are we doing? Where are we planning to go? And then hopefully leave a little time for questions at the end. So I was asked by my fellow chairs and the dean, what is the mission for the Department of Surgery? And I said, well, surgeons aren't really mission folks. We don't sit around and talk a lot about what our mission is. But in essence, we want to be the top surgery program in the state of California in the next 5 years. We want to be the place where patients want to get their care, where students want to come to train and learn, and where people want to work. We want to be the department that everybody wants to be a member of. So where are we now and where are we going? From a clinical care point of view, for quaternary care, the goal is really to be the regional destination of choice and to have people in Sacramento not feel like they have to go to some faraway place to get quaternary, tertiary level of care. And if you think about the programs that have been developed here just in the last 5 years in terms of complicated endovascular care, in terms of complicated and cutting-edge cardiac surgical care, it's extraordinary. It's extraordinary and really leading the way in many and most of these activities. And I will highlight these for each of the divisions as we go through. We have many, many strengths and areas of excellence. Certainly in trauma, we've had a long history of excellence, really being the only level 1 adult and pediatric trauma center in the region and in Northern California. In transplant, we are number 2 in the country in kidney transplant. That is an extraordinary accomplishment, and I will show the growth that has occurred recently. All of you feel that pressure in the operating room because with this enormous increase in growth, we have not increased our operating rooms, and we're all sort of feeling the pressure on that. I will say that by 2015, there are 4 additional operating rooms being brought online, and that should help relieve that stress. But all of you have contributed to the pain and the joy of having developed the extraordinary amount of excellence in that program. And I just wanted to commend that. In surgical oncology, we have an extraordinary excellence in surgical oncology. Our lung cancer program, which Dr. Cook highlighted a great deal about in her grand rounds a few weeks ago, I'm going to highlight again today. Our outcomes in pancreas and sarcoma are extraordinary. In cardiac, it's quite interesting. Cardiac surgery in academic medical centers is a unique specialty because most of routine cardiac surgery, I would say, has moved into our community hospitals, which is in fact appropriate. What is now done in the quaternary and academic medical centers is much more focused on a unique patient population with very complex kinds of care. And it's interesting that across the UC systems, one of the things that is occurring is that the UC system, so UCLA, UC San Diego, UCSF, UC Davis, UC Irvine, are coming together to leverage the strength of their buying power, the strength of many of their clinical outcomes evaluation mechanisms, and a variety of activities. And Nihilus Young has represented the Davis Department of Cardiac Surgery and Orthopedic Surgery. So those are the 2 areas where this activity is most intense right now. This all happens behind the scenes. You don't hear about it a lot, but Nihilus has been spending a lot of time at Berkeley, at UCOP, And I think we were all a little surprised to find that, in fact, from an outcome point of view, UC Davis has some of the best outcomes and the best outcome for some of the evaluation periods in the UC system. So it was a great opportunity for leadership for us. We've talked about how we are growing some of our programs and places that we want to add to the expertise that already exists. And certainly, I think you know that we are recruiting in colorectal, and we have a colorectal surgeon that will be starting with us in July to join the work done by Vijay Katre and Catherine Trotman in this area. We have 2 additional recruits in the way there. Hepatobiliary, fellowship-trained hepatobiliary surgeons will be an area of a next target for our recruitments from a clinical point of view. We have open recruitments right now in breast cancer surgery as well to bring that area into a more specialized area of work. And we are adding to our pediatric surgical expertise and developing the academic side of that program as well. And I think most of you know that Dr. Hiroshi, both a sort of top-notch, minimally invasive and fetal surgeon, will be joining our group in the fall. So lots is changing in the context of clinical care. You'll hear faculty talk about tighter margins and the need to increase cost but decrease utilization. We've got decreased NIH funding to subsidize some of our other missions. The society, the Affordable Care Act, is moving all of us from being paid for procedure to more of a service model, sort of a group approach, and emphasis being on what is the service that's provided to the individual by an organization rather than being paid by Medicare necessarily for each specific procedure. And there's increased integration and sharing of the risk in our hospital. We are now part of a much larger organization where we all share the effect of our rankings, if you will, on increased pressure ulcers. That affects on all. It's just not your own data that's looked at and your particular patient. But so we are, what we do and what other of our partners do impacts us across the board. So, you know, how do we think about how we're going to move as a department to maintain the excellence that we strive to continue to diversify our portfolio of offerings to continue to help us grow, and looking for other sources of revenue, putting increased emphasis on philanthropy. And I'm pleased to say that we have 2 new professorships that we're going to be able to develop, one in general surgery and one in burn surgery. That's a result of some successful efforts in philanthropy, many of which were started by Dr. Wisner. And these help us to be able to subsidize the research and the discovery portion of our mission. I think the other thing that is interesting is seeing the tremendous shift by payers and by consumers, if you will, of patients, in the focus on the patient experience. Customer service is really coming to the fore. I have to say, when I started in academic medical centers, people used to say, it doesn't matter if patients have to wait. We're famous. They could wait for us. Well, that way of thinking just doesn't fly anymore. I don't want to take care of this patient, or this is not my problem, is not the way that we're going to be successful going forward, and not the way that any of you are going to be successful as individual physicians. The answer is not, no, not my problem. The answer is, how can I help you? And I think that's an important thing to understand, that this is a transition. It is not the sort of ivory tower, we're so great, they can wait a month to get in to see me. Nobody wants to wait a month to get in to see you, no matter how famous you are. And famous doesn't really cut it anymore. So it was interesting so this isn't just me talking. This is, and for those of you who keep up with the literature in healthcare reform, these are real data. If you survey the #1 reason for choosing a doctor or a hospital now, it's not necessarily your reputation or your NSQIP data, but in fact, it's the patient experience. what was it like? And think of yourself when you're a patient. I know I went to see the ophthalmologist. If I had to wait 10 minutes in the waiting room. I said, forget it. I walked out of the place. You know, think of how many of your patients are waiting more than 10 minutes in your waiting room. When you self-reflect that way, you realize we have room for improvement, as we would say in our M&M, on how we do customer service and patient care. And if it doesn't matter to you just because it's the right thing to do, be aware that your scores and your metrics now reflect this kind of work. And so if you're the person who needs to study for the test, I want you to know that the test has moved in this direction. We talked, a lot of this, the faculty will recognize is coming out of some of our faculty retreats that we've had over the last couple of years since I've been here. One of the things we realized in the department is that we didn't really know very much about coding or how to dictate or how we said influenced how we were reimbursed. For people who are in private practice, they've known about this for a long time. Certainly in the private practice part of my career, this was an important part of what we do. And I want to just highlight the work that Benson has done in terms of trying to teach folks how to accurately reflect what you're doing. And again, it's not so much knowing the codes, because we have coders who do that for us here. We pay for those coders to do it. But they can only get information if we dictate everything that we did appropriately in the op report, or what we did in our E&M codes, or what we said in our notes on the wards. So these things are important. And it's mostly about getting paid for what we do. This is not about getting paid for what we didn't do, but making sure we do get paid for what we do. Because just in case any of you don't know, there are no other sources of revenue for the Department of Surgery. So somehow people think that because we're a state institution or because you work for the university, that somehow the university is paying for something. Well, the university gets its money from 3 sources. It gets it from tuition, and I can tell you that that tuition money, so the medical students do pay tuition, that goes for paying for the medical school enterprise, the deans, the curriculum, all of that sort of stuff. The second piece, the second place that we generate revenue is from grant funding. So for the few people that do research, grant funding is an important thing. The rest of it comes from clinical enterprise. So for us, who is a relatively small research group, that means all of our money, all of the things that supports the things we do for the residents, all of that comes from clinical revenue. So that's why these things are important. And whether you're motivated by studying for the test, or whether you're motivated by doing the right thing, paying a pension to this is important. And it's why I harp a little bit on the faculty, and that trickles down a little bit to the residents, about the importance of the patient experience, customer access. And I don't want to hear that anybody says, no, not my problem. The answer is, how can I help? It may not be exactly my area of expertise, but how can I help get you to where you need to go and to find the right area of expertise? So a little bit of a... So let me just highlight some of the great strengths and some of the conversations that have come out of some of our divisions. So the divisions all met as groups to talk about what they wanted to do. And I'm not going to spend time having you look a lot at the details of this, but you know, what new stuff can we do? What new procedures can we do? How can we brand ourselves? These are some of the kinds of conversations and the goals that came out of the cardiac surgery group. And let me just again go back and highlight one of the great strengths of our cardiac surgery group, which is the thoracic surgery division. Now this is a little bit more granular kind of data. This comes from the American College of Surgeons NSQIP. And the difference between NSQIP and the publicly reported data, and I know that Dr. Holcroft talks about this a lot, is that we have trained nurse abstractors who actually go into the chart, get the actual data about the patient, and risk adjust it. You know, the difference between a 25-year-old who was hit by a car and has a lung injury is different than an 86-year-old who's having the same lung operation for metastatic cancer and the risk factors and comorbidities that are associated with that. The problem with the publicly reported data, some of the financial data that is collected, is that there's no risk stratification. So we as surgeons tend to believe, and I really think that's the importance of the NSQIP data, we're willing to believe that data. We're willing to say, okay, yes, they've adjusted this for my patient who's got all these other comorbidities, and compare that. So given that, so reviewing the data for the year in 2012 to 2013 in thoracic, and this is the kind of data that comes out of NSQIP, we achieved exemplary status for mortality, postoperative pneumonias, unplanned intubations. Our morbidity was at the as expected level, the ventilator data greater than 48 hours, DVT, and UTI was an area that we recognized at the time was a need for improvement. That's come out of the NSQIP data, and I know you've all heard Dr. Holcroft talking about that. We've talked about some of the challenges around particularly UTI and how we measure the data here. But the point is, these are data that we can believe, these are data that we can act on, and these are data that we can use to make changes in our practice. For all of us now, we not only, for our board recertification, not only do we need to look at this kind of system-wide and institution-wide data, but we are now looking at it from an individual data point of view. And you need to participate in some of these data sets or report your individual outcomes for the number of recurrent hernias, the number of DVTs, in order to sit for recertification. Again, just to summarize, in lung cancer, the volume of lung cancer surgery has been increasing over the course of the last 3 years, and it's really a credit to Dr. Cook and his team. Our operative mortality is lower than the national average. The 5-year survival for cancer patients treated at UC Davis is better than the national average. And we have excellent retention of patients in lung cancer. And lung cancer is really an area of extraordinary expertise here at UC Davis, not just on the surgical side, but also on the personalized medicine side, our mouse biology programs, our personalized data programs, the work that's done by Dr. Gandera, and the work that was highlighted by Dr. Cook a few months ago. Surgical oncology also participates in a variety, the CQIP program, part of the National Cancer Database, that is a joint program of the Commission on Cancer, which is a subset of the American College of Surgeons, as well as the Cancer Society that began in 1988 to try to pool data to try to improve the outcomes for cancer patients. And I can just give you a little example of that on the pediatric surgery side, because that's what I know better. But to just give you an example of Wilms tumors, we know that there are 500 Wilms tumors in the United States every year. And which means if you divide that among 50 states, that's 10 in each state a year. Now, that's not quite how the population distributes. But the only way that we were ever going to learn how to make an impact on Wilms tumor was by pooling all this data nationally. And actually, pediatric cancer led the way in this, and this was followed up in adult cancer as well. The survival in Wilms tumor in the last 20 years, just 2 decades, has gone from somewhere less than 50%. So 20 years ago, if you, those of us who are old enough, had a Wilms tumor, you only had a 50% chance of surviving. The survival for Wilms tumor is now well over 96%. So these are real changes. And by pooling data, these are the kinds of changes that can occur. That's why being part of these large organizations make real-world differences in what we do. So CQIP is the adult cancer database, and it's a joint effort between the College of Surgeons and the American Cancer Society. And my experts are in the room, so if I get this not quite right, just pipe up. But I just want to show you the one of the recent reports that came out. And while this was brought initially to my attention regarding lung cancer, just look at our data if you compare all the COC, the Commission on Cancer sites, so these are all our National Cancer Center institutions, as well as others that participate, compared to our facility mortality for pancreatectomy, for Whipple procedures, there's a lot to be proud of. Rectal resections, the mortality for this year was 0 here related to, and you have to have enough statistical significance to be entered here. Gastrectomies, esophagectomies, cystectomies, our urology colleagues also do outstanding work. So we really have a lot to be proud of in our cancer center, and it goes along with why they were able to achieve NCI, National Cancer Center, Comprehensive Cancer Center designation. Plastics is another area. The division of plastics is really grown with respect to its microvascular work in particular, and is really working on its collaboration with other departments in terms of the complex work we do. We are not a plastic surgery program that is primarily focused on cosmetic work and those things. We do the most complex reconstructive kind of work possible, and you all have participated in many of these consults related to flaps for extraordinary wounds and injuries that we see. And the development of research activity in the Department of Plastics is really growing as well. SGI and bariatrics, I don't see Dr. Ali, but you know, they are, oh, there you are. I didn't have a slide on ISAT, but for my next talk, I want that from you. We, you know, really sort of redefining the area of minimally invasive work to engage and bring to the region and the community a lot of these advanced technologies, the NOTES procedures, the natural orifice procedures, a lot of the new technologies around anti-reflux disease. This is an area that's just taking off, and our division has a lot of leadership around that. Transplant. Again, I think all of you have heard the data before, but I just want to highlight it as we take a careful look at ourselves this year. The kidney transplant program is one of the top 10 kidney transplant centers in the country, and here they are listed. Again, I will have to say that Dr. Fleschlag was very happy to have these data when she went back to receive her award as the outgoing chair at Hopkins, and able to highlight the work at Davis. But what I really want to show you is, I think this graph says it all. And again, for those of you that are in the OR at night, and I know we have a lot of struggles with getting elective cases on, getting urgent cases on, sort of the battle between, you know, whose case is more urgent. A lot of this has to do with the enormous increase in volume of our kidney transplant service, really starting in 2009. And what they've been able to do, it's not just increase the volume. So we are the top program in cadaveric donor kidney transplants. We are ranked second in total kidney transplants, first in kidney transplants from a deceased donor, and first in adult kidney transplants. I mean, this is extraordinary. But it's not just the number, it's the outcomes. So our median wait time, we are able to get patients to kidney transplant faster. Their wait time is lower, their transplant rate is higher. Our decreased donor graft survival at the 3-year mark is better than the national average, as well as our donor survival, kidney survival. So there's a lot of innovation that's gone on in transplant around how to use kidneys that might otherwise be discarded, and technology and research now underway on how to preserve kidneys and sort of regenerate kidneys that might otherwise be discarded. The long wait times have impacted that. So while we're having trouble getting our lap choles in, we're also having trouble getting our kidneys in a timely fashion. So having 4 new ORs is really going to help us a lot. Trauma. You know, it's tough when you're already a great division to make a division greater. But I'll say that that hasn't kept the trauma group from trying to push the envelope to do new things and really look at the ways that we can enhance the work that we do in trauma. I will say that there's more activity in trauma in the region, not surprisingly, but we remain by far and away the destination for the most complex injured patients, both mostly from Tahoe, from our enormous traffic that comes through the area, and through the helicopter work that you guys hear all weekend long. So we have 9 trauma faculty at the present time, a variety of volunteer military faculty who are a critically important part of what we do. And not only that, we are a critically important part of what happens for them. And I think the presentation earlier today really highlights how we contribute, in very real ways to the outstanding work that our military colleagues do. And our partnership with the Air Force is very special, not only in trauma, but in cardiac and in vascular, where we've developed these joint programs which have allowed us to raise the bar for care, not just at our hospital, but at the hospitals that we participate with. The initiatives that are underway in trauma are really exciting, and there's an enormous amount of change happening right now in trauma. So change always has a little bit of stress associated with it, and I just want the residents to know that these things are happening, and it's a challenge for the faculty as we reorganize trauma into 3 essentially separate divisions of acute care surgery, trauma care, and critical care. And this will be underway, is happening right now as we speak, and this is all in the service of trying to meet that goal of better service for our patients. Get Dr. Anderson's semi-elective patients into the operating room in a more timely fashion, so we're changing how the OR is arranged for trauma. Having in-house availability for our critical care patients all the time. It's really been an area where we've seen a little bit of a hole, and I understand that the thoracic team is transitioning some of their night coverage to our in-house critical care service as well, and I think that really provides a higher standard of care for some of these complex patients. So we're working a lot on the teletrauma activity. We don't want patients to have to be transferred here if they don't really need to come here. And how can we help some of our community hospitals be able to give them advice that might allow a patient to stay closer to home? It's really about trying to do the right thing for patients. How can we teach our trainees better? How can we use simulation? How can we have it not be quite so much a learn on the patient kind of activity? I mean, there's sometimes no alternative to doing something for the first time, but we've learned a lot in surgery and in other kinds of training that it really isn't the best way to learn or the best time to have it be the first time. You really don't want it to be you when you hit that tree at Tahoe that it's the first time somebody's doing this. And so how can we model some of these advanced technologies? And a lot of this work we do both at Travis in the large animal facility as well at UC Davis in the large animal facility, and a lot of work that Jonathan Pierce and the team have done to enhance our training around simulation is really useful. And again, if we're sending some of our interns and our colleagues from the Air Force out to battle, we want them to be equipped with the skills that they're going to need when they get there, and just have some of that muscle memory. They know how to put in those shunts. They know how to make the moves before they get there. So trauma has its own NISQIP kind of activity, the TQIP program. And here you have to read it. Dr. Galante showed this a few months ago, but Lowe is good here and really doing exemplary work in all areas, and particularly stand out in traumatic brain injury and across the board. So again, the Caterpillar, for those of you who are new, for our new interns and people who haven't looked at these NISQIP kinds of data and the Caterpillar charts, if you will, in general, you want to be at least as expected, kind of in the blue. And then if you're an outlier in one way or another, either in the red side, which is the bad side, or the green side, that's a good side, how can we learn from each other about what is it that makes a high-performing center? What do they do differently? Or if you're an outlier, hey, maybe that's a message that you need to improve. There are a lot of hospitals not just academic medical centers, but all kinds of hospitals that participate in the NSQIP program. So we can be proud of UC Davis from a trauma perspective, and we shouldn't be surprised. Trauma has been one of the areas that we've had tremendous leadership since the early days of Dr. Blaisdell. And the problem and the challenge, of course, to Joe is that you don't want to be the guy that's the leader when it goes down. So it's almost harder to take over a great program than it is to take over a challenged program. So there's a lot of pressure to keep this great. There's not a lot more green you can get there, Joe. So just don't want you just know the pressure's on. So, and not just mortality, but morbidity as well. And I think trauma has also moved. Great success. We can save patients now, and I think the military has really showed that. And in the last set of conflicts, there's been enormous mortality. Now the next question, improvements. The next question now is how can we improve morbidity there? So, vascular, again, amazing amount of teamwork, a new growth in that department, the lots of vascular surgery research that's occurring, both in the stem cell perspective as well as the looking at outcomes, and some of the work that's been done by Dr. Hedayati and colleagues there has really been leading the way for research in that division. So I want to talk a little bit now, not from a divisional point of view, but just close with talking a little bit about what are we doing with respect to research. I have to say that with the exception of Ki-Ho Cho at Shriners, the only PhD who was in the department left immediately when I arrived. I tried not to take that personally, since research was supposed to be something I was contributing to here. But we really had not much infrastructure for contracts and grants. We've been able to hire a grant manager. Chris, I know you're here somewhere. There you go. And a grant writer in the front here, Connor Long. So we've been able to enhance our research activities not only by the work of the individual faculty, but hopefully to help the faculty do this. We as surgeons are very busy clinically. So having a research infrastructure has been an important part of what we've wanted to bring. And we have to squeeze this activity out of those clinical margins. There's no sort of extra magic that comes here. So it's part of the contribution that we make as academic surgeons to the bigger enterprise. And we need it sounds cliche, but the sum is greater, the whole is greater than the sum of the parts. So everybody contributes, whether they're strictly a clinician, whether they're doing some research work or they're doing a lot of research work. We need it all to make it work. And our submissions for grants have increased over the last 2 years by 200%. I mean, that is really an extraordinary testament to all of you, and I hope to the help of the research infrastructure. And our plan is only to grow that research infrastructure, and trauma is our next area where we're going to be putting effort into that. And to compete a bit, if you will, with our ER colleagues who have an enormous research infrastructure that allows them to utilize this amazing patient base that we have. So we've identified really 3 areas of focus for the department with respect to research. Injury and inflammation, which really cuts across both burns, trauma, and transplant. Regenerative medicine, which cuts across all the departments, and the great leadership that Doug Boyd in cardiac has put in his outstanding CIRM grant. We're looking at this in transplant. We're looking at it in pediatrics. We're looking at it in plastics. And device and development testing, and really leveraging our large animal facilities. The collaborations are the key to success for us. We've got a broad research vision that the research committee of the department is putting together to really help us focus and foster the kind of work that we want to do. Here's just an overview of the response to injury center activity that's going on by a small subset to really enhance this group. The burn division, I think, is a great example of the triple threat in terms of clinical excellence, research, tremendous amount of funding, and teaching in terms of how they train fellows from a variety of places, developing a national curriculum. And I just have to highlight that we've had 2 presidents of the American Burn Society in our department. That's pretty extraordinary. So congratulations. If you haven't been over to the third floor of the research building, the Department of Surgery has the entire third floor there. We now have 9 PIs in that space, and a lot of great work is going on. We have 6 PIs that are there right now, combination of MDs, PhDs, and MD PhDs doing a variety of work in collaboration for many diseases that cross all of our departments. We have residents, medical students, all kinds of trainees that are participating, and I encourage you, and we'll hear more across the year about what's going on there. The Injury and Inflammation Research Center, again, is being expanded out of the burn department to incorporate our transplant and our trauma divisions, and are really going to move this to extraordinary heights of excellence. Dr. Wisner helped launch redefining our Centaur program, which is a collaboration with the veterinary school to really highlight the use of large animal models for human disease modeling, as well as a facility for training and growth, and as a conduit for our colleagues that are in industry to utilize the capacities and partner with us here at Davis for their device development as well. So it's really three-pronged. It's research, it's industry device development, it's incubator activity, and it's training and teaching through simulation. And Dr. Wisner's brother happens to be the chair of surgery. Actually, it's surgery and imaging. It's a combined department in the vet school, correct?
He's really a radiologist. Don't call him a surgeon.
So this is a little hint of why this hadn't happened sooner, and I just forced the 2 Wisner brothers in a room and said, make this happen, you guys. So that was my contribution. So I'm really excited about things that are happening in device development, and I really want to call out Ben Keller, who's made this happen. We probably are going to be poised to put in a device consortium grant in another year, but he has developed enormous relationships with our partners in the School of Engineering. I mean, taking advantage of this expertise across the causeway, and he is developing the ESOPHA-AGI trial, great name, which is a dissolvable, expandable stent that particularly for pediatric surgical indications, but there may be activity in others. And this is just one example. A liver retractor, a few other, a variety of these things are happening. And this is the kind of work that we can really use, that we can really highlight to leverage and capitalize on our colleagues in engineering and the law school around intellectual property, around information technology to do this sort of work. So again, there's robust ongoing thinking around developing of research in the department. Here's just a view of our stats that Chris put together that we've really been, in a very difficult funding time, we've been able to continue to do well. Appropriately, we've shifted a little bit from federal funding to private funding, but we're growing all of it is the point. And that's just continuing and looks really even to be better on target for this year. Just an example of the different kinds of funding over the course of the years. And I'm a little over time, but I just want to say most of the residents who are new residents certainly know about our 3 tracks. We're really focusing in 3 areas for our general surgery residents and our residents that are coming in. We have the traditional surgeon scientist track, and that's really mostly around translational science work, I would say. Again, highlighting device development, the things that Davis has that we can leverage. Our comparative effectiveness and public policy is also a great strength at UC Davis, and I just want to put a shout out to Garth, who is part of an enormous grant that was just received, that he's one of the investigators on, looking at some of the comparative effectiveness work, and it's a several $million grant over the course of the next 3 to 5 years. And so congratulations to Garth on that. And this was just yesterday that I found out about it. And then our 3rd track is the global and rural surgery track. We, I don't see Burke, are you in the audience? You know, spent a year in South Africa this last year. We have residents this year that will be going to our site at Barton in South Lake Tahoe, and we have sites being developed in North Lake Tahoe and also in Wyoming. And this really is an important program for us. I think many of the skills we've talked about that are needed for global surgical work are the same that are needed for rural surgery work. You know, you don't have ERCP. You know, where here we don't do common duct explorations anymore. We don't teach people how to do a laparoscopic common duct exploration that I learned when I first started doing this, because we utilize ERCP. So there's different technologies that you need when you're in different environments, and really linking the development of rural surgery and global surgery is an important part of our educational program that's continuing evolution. The other thing about global health is that I think you're going to see new emphasis on this at campus-wide and university-wide, and leveraging the great strength in the ag school and the veterinary school around the trainee of a different kind of practitioner in the future. So we may not want doctors in many of these resource-limited environments, and you may need somebody who can not only can do an appendectomy or do a C-section, but can also spay and neuter the wild cats and dogs in the environment, or take care of the animals that are an important, and you guys are laughing at me, you know, if you've been there, you know. And or take care of the incredibly important animal husbandry animals that an entire community may be dependent on 2 or 3 goats or 1 cow, and if that animal goes down, that has an enormous impact on an environment. So there, I think, is going to be more emphasis from an institution-wide on the One Health aspect of the work at UC Davis. And then again, just to summarize, we are a big program. We are one of the largest surgical education programs in the country. The average general surgery residency program is 6. The University of Chicago is 4. We are an enormous training program, not just in general surgery, but now in vascular surgery, plastic surgery, and cardiothoracic surgery. Therefore, we have an enormous moral responsibility to train right-thinking doctors to do the right thing, to take care of patients in the best way. And it is a credit to all of the work that is done here by every single person that we are able to pull this off, this enormous teaching effort that we have here at UC Davis, and that we have a lot to be proud of. This is just a slide to remind me that we have a 100% pass rate among our general surgery training group in the board. We have enormous educational infrastructure, really led by Juanita, who's extraordinary, and we are adding and leveraging a lot of these technologies I talked about, the new Center for Virtual Care, and a variety of these activities. We're getting better all the time. We go to a lot of locations. It takes a lot of logistics to take care of everybody. We want to respond to your needs. If things aren't working, if you can't get on the base, we want to know about it. If there are ways we can improve, we want to do better. We are dedicated to this. I would say that that is what distinguishes our program here at UC Davis. Our primary focus is around residency education, and all of our other missions are in service to that. Great clinical care as a role model for trainees of the future. Research and discovery in order to inspire you into the fact that surgery is absolutely the best way to spend your life and the best career. Not only do we have the regular residents that we know, but we have residents that come in from a variety of other rotations from all over, and this is an enormous logistic undertaking. Again, here's our board pass rate, and just because you guys all know I'm kind of a competitive animal, look at this list. Oh, there we go. Vascular surgery has done an enormous amount of heavy lifting to put together an integrated program with the VA, Travis, and UC Davis, which is a model across the country. And there's a commitment to not having this interfere with the training of junior level trainees as well. So I just want to say thank you. And this is sort of a highlight of where we are and where we're going this year, kind of to start the year out. And I ran over all of my time, not a surprise. But I want to say that the scorecard on the bottom is how many medical students go into surgery versus psychiatry. And I was able, the first year, to compete, and psych beat us out again last year. So the gauntlet is thrown. I don't want this to happen again next year. We've got to attract the medical students to go into surgery. So thank you for your time. Do great work this year, and let's do great things.